So is everyone clear about these two pathways, spinothalamic tract and dorsal column tract? So what will happen? Which sensation will be lost and which side of the body if the lesion is below the medulla? Can anyone of you tell me?
Then it's loss of pain and temperature.
On ipsilateral or contralateral?
If it's below medulla, it's
Yes.
contralateral.
Contralateral pain and temperature sensation plus
Plus ipsilateral loss of proprioception, fine touch, and 2-point discrimination.
yes, excellent. Now, what will happen if the lesion is above medulla?
There will be contralateral loss of pain and temperature.
For above medulla, will it be contralateral or ipsilateral pain and temperature?
Above medulla. Well, it's crossing, no?
Yes, yes.
So there must be contralateral.
Yes, it's contralateral. You are right. And
Contralateral loss of pain and temperature, and
uh,
also the proprioception must be contralateral because it's crossing.
yes, that's right. So after crossing, what is the name of dorsal column tract?
Medial meniscus.
Yes, sometimes they will not mention that the lesion is at the level of or above the medulla. They will just say that there's damage to the medial lemniscal system. So if they say that dorsal column pathway is affected, then it means they are talking about the dorsal pathway in the spinal cord. And if they mention the medial lemniscal system, then it means they are talking about this pathway after it has crossed to the opposite side. So we were discussing the structures that are present in the midline and structures that are present laterally. So midline structures are motor pathway. Medial lemniscus is also a midline structure in the brainstem, and damage to the medial lemniscus will result in loss of contralateral proprioception and vibration. Damage to the motor pathway will result in contralateral weakness. And damage to the motor nucleus of the nerves 3, 4, 6, and 12 will result in the signs of cranial nerve damage. And damage to the medial longitudinal fasciculus, ipsilateral internuclear ophthalmoplegia. Now, what are the lateral structures? Lateral structures is spinothalamic tract, which will result in contralateral pain and temperature loss. So, if you can remember the lateral medullary syndrome, what happened in the lateral medullary syndrome, or what were the signs of lateral medullary syndrome? Anyone?
Ipsilateral Horner syndrome
Yes.
and also the contralateral loss of pain and temperature sensation in the limbs.
So you can see that sympathetic pathway or sympathetic chain and spinothalamic tract, both of them are lateral structure. Is that right? Both are lateral structure. So that's why in lateral medullary syndrome, as its name indicate, the lateral medulla will be affected. And as sympathetic pathway is present laterally, spinothalamic tract is also present laterally, and sensory nucleus of cranial nerve 5 or spinal nucleus of cranial nerve 5, which is bringing pain and temperature from the face, is also present laterally. And also a pathway, spinocerebellar pathway, is also present laterally. So in medial midbrain syndrome, what happened? In medial midbrain syndrome, midline structure will be affected. What are the midline structures? Contralateral weakness or contralateral hemiparesis, along with cranial nerve palsy. Both of them are medial structures, so that's why in medial midbrain syndrome, the midline structure got affected, and it results in the signs and symptoms of corticospinal crack and cranial nerve nuclei of third nerve. Lateral medullary syndrome results from the occlusion of posterior inferior cerebellar artery. What other nerves originate from the medulla? What are the nerves that originate from medulla? Anyone tell me?
So 9, 10, 11, 12.
Are you sure? Yes,
First
it's
two,
9, 10.
3, 4 from midbrain, 5, 6, 7, 8 from pons, and 9, 10, 11, 12 from medulla.
So lateral medullary syndrome can also have signs of other cranial nerves such as glossopharyngeal and vagus nerve as well. We have already discussed Horner syndrome. Horner syndrome is characterized by meiosis, ptosis, and anhidrosis. It is caused by a damage to the sympathetic nerves of the face, and the sympathetic nerve of the face is the sympathetic supply to the face, or the sympathetic nerve to the face, basically originate from the hypothalamus. They travel down in the brainstem. So sympathetic chain or sympathetic pathway, is it a midline structure or is it a lateral structure?
Sir, it's a lateral structure.
Yes, it's a lateral structure. So damage to the sympathetic nerves to the face can result in the Horner syndrome. What is the function of the sympathetic nerves? They cause pupil dilatation or mydriasis. So damage to sympathetic nerve will result in meiosis. They supply the sweat glands. So damage to them will result in anhidrosis, and also they supply the muscle of the eyelid, superior eyelid. So these three symptoms will develop, which is called Horner syndrome, due to a damage to the sympathetic nerves. A damage to the sympathetic nerves can be due to tumor, it can be due to stroke, any injury, or any underlying disease that is affecting the surrounding area, that is around the sympathetic nerves. So levator palpebrae superioris was supplied by oculomotor nerve, while the superior tarsal muscle receives its innervation from the sympathetic nervous system. So a damage to the oculomotor nerve will also result in ptosis, but ptosis will be associated with mydriasis in oculomotor nerve palsy. While in sympathetic nerve palsy, ptosis will be associated with meiosis. So now we know how to differentiate between the brainstem lesion and cerebral cortex lesion. So how or when you are going to say that it's a cerebral hemisphere infarct, if the patient has contralateral hemiplegia or contralateral sensory loss along with dysphagia or homonymous hemianopia, then we can say that the location of the lesion is cerebral cortex. What are the key points for a cerebral cortex infarct? Contralateral hemiplegia, contralateral sensory loss, hemianopia or dysphagia. And if with contralateral hemiplegia or contralateral sensory loss plus signs of cranial nerve lesion, then we will say that it's a brainstem infarction. Now, when you will say that it's a cerebellar lesion, we have discussed cerebral lesion, brainstem lesion. Now it's time to identify or diagnose cerebellar lesion. It's important to know the signs of cerebellar lesion because in cerebellar lesions or posterior circulation infarcts, the investigation of choice will be MRI and not CT scan. So what are the signs of cerebellar lesion? The signs of cerebellar lesion is dysdiadochokinesia. Remember that the function of the cerebellum is to coordinate the different movements of the body. So if there's a lesion in the cerebellum, a person will be unable to perform rapidly alternating movements, which is called dysdiadochokinesia. There will be ataxia, loss of balance, nystagmus, intention tremor, slurred speech, hypotonia, and past pointing. So if someone presents to you with these signs and symptoms, then the lesion is most probably at the level of cerebellum. If he is unable to perform rapidly alternating movements and there's nystagmus and ataxia plus past pointing. What is past pointing? If you ask the patient to touch his nose, after touching your finger, then the finger goes beyond the nose, which is called past pointing. So cerebral infarct, cerebellar infarct, brainstem infarct, and now the fourth one is lacunar infarcts. Remember that lacunar infarcts will result in a pure motor or pure sensory lesion. Like the patient will have only hemiparesis or only hemisensory loss. There will be no other sinal symptoms. In case of cerebral cortex, along with hemiplegia or hemiparesis, there will be other signs and symptoms such as homonymous hemianopia or dysphagia, while in case of lacunar infarcts, there will be no such symptoms. The lesion will either be pure motor or pure sensory, or mixed motor or sensory can be there also. But there will not be any signs of brainstem lesion such as cranial nerve lesion, or no sign of cerebral infarcts such as homonymous hemidopia or dysphagia, etc. So is it clear to everyone? Can you differentiate between cerebral infarct, brainstem infarct, lacunar infarct, and cerebellar infarct? Can every one of you differentiate between these four, or is there still any confusion? Is a question. Lacunar infarct are basically small infarcts, mostly in the internal capsule. There are two limbs of internal capsule: anterior limb of the internal capsule, posterior limb of the internal capsule. The posterior limb of the internal capsule contain the fibers or motor fibers, and the anterior limb of the internal capsule contain the sensory fibers. So a lesion of the posterior limb of the internal capsule will result in a pure motor stroke. Pure motor stroke, what is a pure motor stroke? Such as a person will have a face, arm, and leg weakness. This is a pure motor stroke. Face, arm, and leg weakness, right-sided face weakness, right-sided arm weakness, and right-sided leg weakness. There is no other symptoms. like there is no cranial nerve sign or no cerebral cortex sign, such as homonymous hemianopia or dysphasia or aphasia. Now, what will be a pure sensory stroke? Loss of sensation on the right side of the face, right side, right arm, and right leg. It is a pure sensory stroke without any signs of cranial nerve lesion or without any signs of cerebral cortex lesion such as homonymous hemianopia or dysphasia. Now, if you mix both of them, that there is mixed sensory and motor loss without any signs of cerebral cortex lesion or cranial nerve lesion, again it will be a lacunar infarct. Is it clear now? Now you can identify or diagnose a different type of infarcts. Now a person present to you with ataxia, unsteadiness plus nystagmus plus slurred speech. These are the symptoms or signs of cerebellar lesion, ataxia, loss of balance, nystagmus, and slurring of speech. Plus, there is a lesion of cranial nerves such as vertigo, diplopia. So, if someone present to you with cerebellar signs plus cranial nerve signs, then it is a brainstem lesion because this cannot be a cerebellum only lesion. Cerebellum cerebellum only lesion will present to you with signs of cerebellar lesion, and there will be no signs of cranial nerve lesion. So if a patient has both of them, then you will say it's a brainstem lesion and not a cerebellar lesion, because cerebellar lesion does not cause cranial nerve symptoms. However, cranial nerve lesion can cause similar features to cerebellar lesion because, as we already discussed, that vestibulocochlear nerve is associated with balance, and a damage to the vestibulocochlear nerve can result in ataxia or nystagmus. So if someone present to you with signs which are similar to cerebellar lesion plus there is a cranial nerve lesion signs, then it is a brainstem lesion and not a cerebellar lesion. Now the different type of strokes on the basis of circulation, such as anterior circulation stroke. What will be the manifestation of anterior circulation stroke? What will be the manifestation of posterior circulation stroke? What is partial anterior circulation stroke? What is complete anterior circulation stroke? These topic we will discuss tomorrow. For today, we'll end our session here. If anyone wants